Well, hi, this is Dr. Nick Tullo with my Saturday morning clinical live stream. And for those of you who were here an hour ago, I am so sorry. It is just like major embarrassment when things don't go wrong. And I just wanted you to know that I have created a checklist now. This is kind of like when you're taking off at the airlines, you know, when you're flying a plane. So now hopefully this won't happen again. But just wanted to let you know that if there's ever a problem, you know, please put a comment up. But I think everything's going to be fine now. See, for those of you who have done any kind of computer live stream stuff, it was just a matter of reducing some settings. The microphone was sending too many samples to the computer, but that's not really important. Anyway, thanks for joining me again. Take two. This is a case discussion of a 95-year-old woman with a history of hypertension who was on kind of under the weather, a little tired, hasn't been able to get around the house the way she used to. She actually lives with her daughter, and for the last 2 days, her daughter noticed that she was more out of breath, she was weaker, and the evening of admission, she tried to climb a flight of stairs and got very, very short of breath. And when she got to the top of the stairs, she took a couple of steps, went into her bedroom, and just kind of collapsed on the bed. She never really passed out, but she was like extremely weak. Good morning. Good morning, Wyatt. You figured out the strip already, huh? Well, all right. So when she got to the emergency room, her heart rate was like 35 beats per minute, and the resident called and said it was a junctional rhythm. So my first thought was that maybe the beta blocker had affected her sinus node, and that she developed severe sinus bradycardia and had a junctional escape rhythm. But let me share with you the ECG. I'll be able to pull that up. Let me just get rid of this here. And we'll take a look at the ECG. And, okay, so it looks like Wyatt has already said what he thinks it is. So I'm on the phone with the resident, and I was like, well, okay, it's a junctional rhythm, perhaps because the heart rate is very slow, the QRS is narrow, but what's the atrium doing? And if you look at this strip down here, here, let me just make a few marks here. So the QRSs are very slow. The rate here is, as I said, about 35 or so. But where are the P waves? What is the atrium doing? If this was sinus bradycardia, good morning, guys. Space Fed Elizabeth, thank you. Jazz Winder, Nicola. Hey, Nicole. So thank you very much for joining me. I'm sorry if you guys had tuned in an hour ago. I had some really serious technical difficulties, and it was, my fault. Because I don't have a crew of geeks here making sure that everything is set properly, and admittedly, I was like running 5 minutes behind. But okay, so let's look at this. So Tracy says complete heart block, and I think it's fairly easy to make that diagnosis, because when you start looking for P waves, and you look and you could see P waves, like here's one, and then you kind of look across and say, oh, here's another one. Now, initially you might think, well, wow, the atrial rate is much slower than the ventricular rate. The ventricular rate's faster. And so this is some kind of AV-dissociated rhythm. But as you look across it, you can now see a P wave here. Now it becomes clear that the atrial rate is actually much faster. Well, how come you don't see any others? Well, if you take a pair of calipers, and I could do it with my eyeballs, if you take a pair of calipers, the next P wave would land here in the middle of the QRS complex. And then when you continue to map it across, the next P wave lands on this T wave. And you say, well, how do you know? Well, look at how tall this T wave is compared to this T wave. And you can see the same pattern here. This is a tall T because there's a P superimposed on it. And so the atrial rate is about 60. So you have an atrial rate of 60 and a ventricular rate of like 35. So the A's are going faster than the V's, and there's no relationship between the two. And more importantly, the ventricular rate is perfectly regular because it is an escape rhythm. And yes, indeed, the diagnosis is complete heart block. Just to make sure, I mean, I want to make sure, is everything synchronized properly? Is the quality of the video pretty reasonable at this point? Just somebody let me know that things are okay. At any rate, it looked like complete heart block. And everyone was like, oh, well, okay, we'll schedule her for a permanent pacemaker in the morning. So, but I was just, in fact, I did schedule her for a pacemaker because, thanks, Larry, Tracy, thank you very much for your feedback. It's hard for me to tell what things look like when, out in the mist. So thanks, Nicola. I appreciate it. So, okay, complete heart block. I already called the cath lab. I said, okay, make her NPO. We'll just, see what happens in the morning. But in the back of my mind, I'm thinking to myself, okay, she's on metoprolol. And had this been sinus bradycardia, I would have expected it to get better. But, yeah, complete heart block, yeah, okay. It looks like she's 95. Most likely, this is, irreversible. We're going to just put the pacemaker in. So what happened was I come in the next day and I happen to notice that I'm sorry, let me go back. And this is actually her prior ECG. This was from 4 months ago. And I wanted to share with you guys, I was like, look at that. Just 4 months ago, she had a heart rate of 75 or so. She's conducting 1-to-1 with a normal PR interval. And although the QRS looks just a tad wide, and although, if you notice, the axis is isoelectric in AVR, okay, and it's negative in 2-3 in AVF, and she has a left anterior hemiblock, that the QRS complexes in this strip look almost identical. I mean, she's got the same axis, she got the same QRS, appearance. So this is truly a sort of a junctional escape. And I was like, well, what about that beta blocker? Could that be the cause? So I decided to kind of like hold off on the pacemaker until the next morning. And then the next morning, I came in and I noticed something on her heart rate trends. So here was her heart rate over the last 12 hours or so. So initially, you can see it was perfectly flat, that this was a junctional rhythm. And then she started to have somewhat faster heart rates. And I'm thinking, look at that. And in fact, if you look at the trend, it's starting to go faster and faster. And when I looked at her rhythm strips, and here is her ECG from like the next day, before we were going to put the pacemaker in. What does that show? Well, now you have group beating. Of course, the metoprolol was held, but it was Toprol XL. So she had taken a dose only by maybe 24 hours ago. And if you have a half-life of maybe 20 to 24 hours, there's still some of it left. Before, and you have group beating, and you still have you have second degree AV block now. It's not complete heart block any longer. Now, can anybody tell me if it's type 1 or type 2? If you notice there are 2 PR intervals in a row, and the PR looks to be getting longer before the blocked beat. And so Nicola is right, this is Wenke back. type 1, second degree AV block. Now, when you put the whole picture together, you have someone who appears to have second degree AV block. It's getting better off of the beta blocker. If you had to guess where there's a level of the block, would you say that it's inside the AV node, or is it below the AV node? Is it infranodal? Because that's really ultimate left anterior hemiblock. So yes, she has some disease in the bundle branches, but the fact that we have winky back now and that you have progressive prolongation of the PR interval, to me, tells me that the block is within the AV node. It's intranodal, otherwise known as suprahischian. And I said, wow, this is great, because where does metoprolol work in the conduction system? Yes, it suppresses sinus node function because it blocks sympathetic input to the sinus node, but it also affects the AV node. And now you have AV block that seems to be getting better off of, you had heart rates that were, in the 50s now. If you look back at the trend, you see heart rates that exceed 50 beats per minute. So I went back to pages and pages and look at what I found. Not only was there periods of wanky back here with the PR getting longer before you block a beat, but she started conducting 1-to-1. Look at that. Granted, there's a first degree AV block, but she's also still has some metoprolol in her system. And so I said, well, if this is intranodal block, that's right, Larry, if it's blocked within the AV node, and we know that 95-year-old patients don't usually tolerate medications as well as a younger patient. So what are the chances of her AV block getting better? And so the nurse looked at me and she said, well, understanding the physiology, and when you start to see wanky back, it tells you that the block is higher up in the conduction system, that you have the potential for medications inducing it. I mean, after all, yeah, sure, she's 95 years old and she's very functional, and it would have been very easy to just throw a pacemaker in her. But pacemakers have some detrimental effects, don't they? I mean, after all, there's a risk, at least in my institution, the risk of pacemaker complication is admittedly very low. I mean, but theoretically, there could be a 2 or 3% risk of infection, another 3% risk of a hematoma. You could have thrombosis of the axillary vein and causing serious adverse effects and serious symptoms. Not to mention the fact that pacing in the ventricle could have detrimental effects on left ventricular function. Now, and I think in her case, had her arrhythmia been serious, I would have just put a pacemaker in. But that's why I gave it a second thought. And I was like, look, if this woman's AV block was due to the beta blockers, and now her AV node is perking up, then why would we put a pacemaker in her? Because after all, we know that first degree AV block, which is what she has now, is not an indication for a pacemaker. And we also know that the type 1 second degree AV block in the States, in the absence of symptoms and with fairly adequate heart rates, is also not an immediate indication for a pacemaker. So that's why I decided to hold off. And that's why I wanted to bring this case to you, because most people would just have thrown a pacemaker in her. And I just wanted you to realize my rationale, my thought process is, where's the level of the block? And if it's potentially reversible, then it's reasonable to hold off for a day or 2 days just to see what happens. So that's what we did. This was just yesterday. So, and I said to the family, I said, look, if over the weekend her AV conduction continues to improve, and, she's months ago. It's hard to imagine that someone has, sudden acute onset complete heart block in just 4 months unless it's infranodal. So if you have conduction system disease, if let's say she had a bifascicular block, and then she developed complete heart block, I was like, that's not getting better. That's not from medications. The beta blockers have very little effect on the conduction system below the AV node because those are sodium-dependent channels. They're all or none. And once you get trifascicular block, that ain't getting better. But the fact that it was suprahysian, intranodal, above the AV node, means that potentially it was due to the medications, and that's why I decided to hold off and see what happens. Because again, she had a normal PR interval just 4 months ago. And what I'm hoping is that she'd go back to that point, and then we can save her from having a pacemaker implant and invasive procedure. So I'll just take a look at some questions here. Okay, and it's all about, again, it's all about where you think the level of the block is. Because if you have a wide QRS complex, then either the patient is conducting with a bundle branch block or they have an escape rhythm down in the ventricles. So if you have an escape rhythm in the ventricles, so-called idioventricular escape, most likely you're dealing with block below the His bundle or in the His bundle. I mean, it's rare. I mean, if you have block above the AV node, then usually you get it down. Let's say if somebody had a right bundle branch block and that was it. Their left bundle is perfectly healthy. They might have a wide QRS escape rhythm at 35 beats a minute, but maybe it's junctional and it's just conducting down with the same right bundle that she had before. So you really have to take the big picture in. You have to figure out, is this an idioventricular escape or is it a junctional escape? And a lot of it depends on how it behaves. And it also depends on what medications the person is taking. So it looks like the patient has trifascicular conduction system disease is probably not going to get better, and you might as well just, go ahead with the pacemaker. So then Wyatt says, I've always had a pacemaker question that hopefully you can answer for me. Okay, Wyatt, what's your question? Why is it that some pacemakers are only pacemakers and some are also defibrillators? Okay, so an implantable defibrillator does much more than just a pacemaker, right? For shock to the heart, in the case of ventricular fibrillation, they can deliver rapid anti-tachycardia pacing into the ventricle to terminate reentry ventricular tachycardia. But you really only need a defibrillator if you're at risk of sudden death. If you have low ejection fraction or if you've already had an episode of ventricular tachycardia, ventricular fibrillation, those are the people who qualify for an implantable defibrillator. Now, what most people don't realize is every implantable defibrillator also has a built-in pacemaker. The thing is that the different models of defibrillator have different degrees of pacing capabilities. So most implantable defibrillators are just single chamber. There's one wire sits in the ventricle and it behaves like a sort of a backup pacemaker. Usually it's programmed just VVI at 40 beats per minute. So if anything happens, have an atrial pacing lead and a ventricular pacing lead. And they're capable of behaving the same way as a dual chamber pacemaker. So you can have stimulation of the atrium and the ventricle. So if you have somebody who needs a defibrillator because they have ventricular tachyarrhythmias or they're at risk of sudden death, and they also have an indication for a pacemaker, like either sick sinus syndrome or some degree of AV block, then you can. And so those have 3 wires. And that technology is known as cardiac resynchronization therapy. And so the 3rd wire, it comes down the vein and it's threaded into the coronary sinus, which is the main vein in the heart that drains the whole left side. So of course, the coronary arteries feed the heart, but there are veins that return that blood back to the right atrium, where all veins empty, right? All the veins go to the right atrium. So the coronary sinus is the vein of the heart. And what you have to do is take a special wire and you have to thread it into that it adds a significant amount of time to the implant. But if you can get that wire into one of the veins on the left ventricular free wall, contraction, and in patients who have a left bundle branch block and left ventricular dysfunction and heart failure, this is known as cardiac resynchronization therapy, or CRT, and that can improve the left ventricular ejection fraction. And about 3/4, no, I would say 2/3 of the time, you actually get an improvement improves their symptoms. So that's what a biventricular ICD is. You can't get a biventricular pacemaker, but most people who need biventricular devices have low ejection fractions, and most of them will wind up getting an ICD anyway. So, yes, so if they're at risk of cardiac arrest and they have sick sinus syndrome, you can use a dual chamber ICD, assuming that their QRS is narrow and they're conducting okay. Because if you have just pure sick sinus syndrome, usually the AV node is conducting straight, and then the defibrillator is there in case they develop any ventricular arrhythmias. So yeah, Nicola kind of answered Wyatt's question. So it's nice. Wow, look at that. You kind of have interaction between participants. And I'm really glad that you guys came back. I'm really sorry for the glitch that happened. I've got my checklist now, so hopefully that won't happen again. This is my 28th live stream, so I'm not, it came out great. I hope you enjoyed this case presentation. It's great to be here with you on a Saturday morning, and I think next weekend I should be able to do it, but just check the YouTube channel. I mean, if you like this content, remember, just click the subscribe button down below. Give me a thumbs up so that I get some positive feedback, and let your friends know that they can subscribe as well. This way you'll get notified that usually at the Friday night before the Saturday morning, I'll send out notification that I'm going to be doing a live stream. If you just looks at a cardiogram and you want to get to be as good as me, then check out ECGacademy.com. Have an entire course from beginning to end, from basic to advanced, and you can watch my videos and learn all about how an arrhythmia specialist is able to look at ECGs and analyze them with the physiology in mind. Thanks.